Hi there, my name is Muhammad Iftal. I would like to share with you a bit about my background before we proceed further. So, I'm currently a PGY6 graduate from the University of New South Wales. I am on the General Surgical Education Training Program with the Royal Australasian College of Surgeons, that is RACS. And at the moment, I am a Set 1 trainee, having done many unaccredited years in the past, as well as RMO and SRMO roles in general surgery. That also includes subspecializations such as vascular and plastics and upper GI. I've also been extensively involved in medical terms or non-surgical terms such as gen med, geriatrics, and especially in emergency medicine as well. So I'll be able to give you a very comprehensive knowledge to support you throughout your journey, as I do have friends who are in the AMC or who have taken the AMC exam, so I do understand the challenges that you would face coming with this exam. So hopefully we could get through this, and I'll be able to share with you a bit about my knowledge or my experience as well, and yeah, hopefully you can benefit from it. There are many things to consider when you have a patient that you would like to operate on. However, I feel that this should be done in a very structured and systematic way. Of course, it's difficult at times when you'd want to do this in a chronological order, but it's a dynamic process, I would say. And of course, certain situations it's just impossible to do it, as I mentioned, chronologically, like in trauma settings. However, I think there should be some foundation in how you approach each case. So I would usually like to start off with making sure that we focus first on the patient. So for example, when I approach a patient or when I am thinking about operating on a patient, the first thing I would want to assess is how unwell this patient is. If I'm thinking that this patient is critically unwell, then that would change in how I escalate this issue, especially when I'm doing nights or when I am on call or in a setting where I'm sort of independent without the consultant or someone more senior around with me on site. So yes, assessing how unwell the patient is, you could first start off with vital signs, looking at bloods, examining the patient, and usually you would get an assessment or a triage information already prior to approaching the patient. So you would want to do that first, and once you've established that this patient's whether it might be unwell yet can be stabilized prior to surgery, or critically unwell, such as in trauma cases where you need to escalate it rapidly to theaters, then you could then move on to asking questions. Of course, you would have all of the subsequent questions already in check when you speak to the patient. So for example, you would want to find out the fasting status of the patient. You could do this in your history taking. It's very important, especially when you're assessing the patient and determining a diagnosis, that you get a thorough history. So one of it is, apart from the presenting complaint, would be checking fasting status. In general surgery at least, or actually in most cases, you'd want the patient to be fasting for 6 hours, unless of course it's a major trauma case, unstable major trauma case which needs to be taken to theaters urgently. Then that's a different issue, in which case fasting status is not an absolute indicator of when the operation can occur. However, if the patient or if the operation is able to be scheduled, then you'd want 6 hours of fasting. That is nil by mouth. You could, in depending circumstances, have patient to take sips of water, because that can provide a bit of comfort to the patient. Clear fluids, there are a couple of discussions about this. but generally you can have clear fluids sometimes even up to 2 hours prior to the procedure as well. But usually free fluids, soft diet, or any form of diet should be abstained 6 hours before. So once you've taken into account of the patient's fasting status, then you want to make sure, or you want to ask the patient about their medications that they take. In surgery, one of the most important medications to know about is anticoagulants, and that includes antiplatelets as well, especially if the patient is taking clopidogrel. These are very important medications to know because they can influence operative approach. Of course, there are means that we can do to reverse anticoagulants, so it's also important, as I mentioned, to know what kind of anticoagulants or antiplatelet they are on, and make note that, for example, in warfarin, you'd be able to reverse the effect by administering vitamin K, and in certain DOACs or NOACs, there are available reversal agents such as Pradaxa or Praxbine, but this needs to be discussed with the pharmacists in the hospital to find out exactly which ones are available and the indication of it. I would also want to just mention here that it's important when you are thinking about the medications that they are on and its effects on or in the peri-operative setting, it will be important to look at the renal function, because a lot of these medications are excreted renally, so having good renal function can at least guide you into how you would go about or when you would want to operate this patient if you are unable to reverse, or if you are unable to have any reversal agents for the anticoagulants. Also, checking liver function is important as well, as this can influence other medications if you would think of giving them, such as simple analgesia as like paracetamol. Excuse me. And if you're already sure that you are bringing this patient to theaters, you're keeping them fasted, you'd want to ensure that you have fluids running for the patient and also having good IV access. So I would always make sure that there is at least one cannula in situ already for the patient, and have fluids running if you think that the patient requires them, if they're going to have surgery in like a few hours whereby they would need to be fasting and there's a potential that they can be dehydrated. The second component is consulting with the relevant medical teams. So I would say that once you've done the assessment, once you have come up with a provisional diagnosis and you'd like to then escalate this further or bring this patient further to the operating theater, speaking with your senior or with your consultant would be very important. You should never bypass your consultant before formally making any medical decision. The discussion is always two ways in my opinion, and you are allowed to be confident in providing your diagnosis and justifying why you think that the patient requires an operation. Apart from your own surgical team, you should consult with the anesthetist and with the with the theater staff, because you would require them to handle the logistics of bringing the patient from the emergency department up to theaters. And if there's any high risk cases, I think you should also promptly bring the anesthetist to attention, as well as the HDU or ICU staff if required, whereby you think that the patient may require HDU or ICU bed post-operatively. So I would usually get the critical care staff involved earlier on and in my experience they don't have any issues with being involved early on, so that they can at least be prepared for severe outcomes if that is the case. And I would also want to highlight that getting consent is very important. Of course, as I mentioned, that all of this does not have to be done in a chronological order, but at least it needs to be done in a dynamic fashion. Consent wise, there is a good guideline written out by the New South Wales Health policy, whereby there are certain criteria which validates a consent. I'm just going to mention a couple of them. So first thing is that the patient needs to have insight. The patient is giving the consent with no external pressure. The patient understands the procedure, the risks and benefits of the procedure. And if the patient is unable to provide consent for whatever reason, be it that the patient is not corpus mentis, or the patient has a formal guardian, then you would need to seek the next of kin to provide that consent. It can be technical at times, whereby if the patient is not able to give consent as they have a guardian that is authorized to do so, you would need to check if the guardian is allowed to give medical consent, because there's two types of consent. Usually there is the financial consent, and then there is the medical consent. So in a case where this happens, then you need to ensure that the guardian is able to give medical consent. And if for whatever reason you are not able to get consent from anyone, you would then need to ensure that, or then there is a duty of care that is on the medical staff to ensure that this patient gets the appropriate treatment. And so this is something that again you need to discuss with your senior, or at least the consultant, to ensure that this decision is an informed decision. The final thing that I would want to say is that there is a checklist that I think it's in fact it's a very standardized checklist that is developed by the WHO, the World Health Organization, to ensure that errors are minimized, be it in the pre-operative, intraoperative or post-operative setting. It's called the WHO surgical checklist. You can get this copy online from WHO website itself, and it's a very good checklist to ensure that all the details are gone through. So just to mention a few, you'd want to, the checklist clearly outlines if the patient has any allergies that needs to be checked, and if the case has been discussed via the anesthetist, and if there is an anticipated blood loss volume, and if the consultant also is aware of the risks. If I'm not mistaken, that's one of the other detail in the pre-operative setting. And then you have the intraoperative setting and then the post-operative checklist as well. I don't think you have to memorize the entire checklist per se. However, I do think you should be able to understand the fundamentals and the principles behind this checklist and its significance in guiding the surgical team in the perioperative setting. So, as I mentioned, just to recap, the patient status, consulting relevant medical teams, getting consent, and running through the WHO checklist are the important foundations in managing a surgical patient in the perioperative setting. Thank you.